Perfect. Well, my name's Kiran Alluri. I'm a spine surgeon out of USC, orthopedic trained. I think I'm in my 5th year or so now of practice, and honored to be a part of this course. Thanks for the invite. And I'll be talking about robotics and spine surgery. Just so I understand my audience a little bit better, to the trainees, how many of you have actually used a robot in the OR? Not in a cadaver lab, not a demo, but in the actual OR? Like a third-ish? How many of you would like to have a robot when you're out in practice? Yeah, like half, 2/3? All right. Well, I'm going to talk to you a bit about the history of robotics, and we'll go over some tips and tricks at the end. Full disclosure, I do get paid to design, consult, teach the robot, mostly by Medtronic, a little bit by some other companies, but it won't influence the talk. I don't specifically talk about a particular robot in this talk. So briefly, like I said, I'm going to talk about the evolution of robotics. I'll show you some of the currently available platforms and what's to come. I'll talk to you about what I think are some of the benefits of robotics. I'm going to talk about cost because I think it's important. I'll tell you where I think the future is going with robotics. And then briefly, I'm going to try to show you guys good workflow, good tips, good tricks, and how to stay out of trouble when using the robot. And so robotics, you guys have all seen the Da Vinci. Robotics has been around in general surgery, urology since the 1990s. Spine surgery has been a relatively late adopter. We didn't really see a full-fledged integration of robotics into spine until like the mid-2010s. So we're a bit behind the game in terms of robotics. But robotics in terms of the Da Vinci's honestly been around since the early 2000s in terms of FDA approval. To date, all spine robots are technically what I call them cobots. They're shared control devices. They're not remotely controlled. They're not independently controlled. They're shared control devices, and that's how all the currently available robots have gained FDA approval. There are some that are coming out that will actually be a bit more independent, but that's a bit off topic. So let me give you guys a bit of background on the evolution of robotics. So surgeons were trying to use robots actually as early as the 1990s in the world of spine, but there were massive workflow challenges. Also back then, like MIS surgery hadn't really taken off, and so these were mostly open cases, and surgeons were pretty good at freehanding, maybe using some fluoro assist, and they found the robot to be very challenging. The workflow was really bad. It was really long to set it up. There was no navigation, right? So you're using pre-op CT and merging, and then you were kind of blindly trusting the robot. You were using guide wires, and you were hoping that what you saw was matching what the robot was thinking, but you didn't get any real-time feedback. And so surgeons really did not like that. And once again, these were open cases. There really wasn't a need for robotics because MIS surgery really hadn't taken off yet. And so people were trying to develop the technology, but the interest and the clinical need in the 90s really wasn't there. But if you look at the papers, there are papers out there, some from South Korea, some from China, demonstrating the use of robotics in spine as early as the 1990s. In the early 2000s, we had significant advancements with intraoperative imaging, particularly the use of CT scanning in the OR. And so this allowed for the merging of CT scanning with the robot, so you were able to get the scan in the OR. But there were still a lot of workflow problems. There were a lot of software crashes. Surgeons became frustrated with the amount of time added to a case. There were a lot of skive issues, and I'll show you how we've sort of overcome that in the last couple years. So there were a lot of medial and lateral breaches, and most of these screws had to be placed over a guide wire, so it was still pretty cumbersome. And once again, these were still mostly open cases. The first FDA-approved robot in the United States was 2004, and it was more of this open-based platform, K-wire-based, without real-time navigation just yet. And so the biggest problem with these initial iterations, what I call Gen 1 robots, was really no real-time feedback, so you're blindly trusting the robot, and there were a lot of software issues, workflow issues, and surgeons were fast. They were fast at freehand technique, and they really didn't want to slow down to sort of integrate this technology that really didn't have benefit yet. And so we have seen sort of exponential growth of robotics in the last, I'd say, decade. In 2019, there were 3 FDA-approved robots. In 2021, there were 4. Currently, I believe there are 9, but you might need to fact-check me on that. Beyond 2025, there are projected to be about 19 robots available on the market. These are all of them. You can see all the major companies are working on robotic technology. There's not a company on here that you haven't heard of that doesn't have a robot. There are some companies that are purely robotics focused, meaning they're building robots to be open platform. But there's about 19 that are about to come to market. So it's a hot topic, and every company is sort of investing in the technology. In terms of benefits of robotic technology, I'm a big believer in robotics. They wouldn't have asked me to come talk if I wasn't. But you see in italics, I have purported benefits. And so these have not been proven, but if you talk to believers in robotic technology, they'll tell you these are some of the major reasons they use the robot, even though objectively it's very hard to claim this. But I believe all of these. And so certainly reduced surgeon physical fatigue, like putting in those screws on hand. That's really, over time, that takes a significant amount of wear on your rotator cuff, your wrist. Spine surgeons have some of the biggest occupational hazard. And so being able to put these screws in on power with minimal physical load, a huge benefit. Cognitive load, I'll tell you about my tips and tricks in a minute, but when the robot is putting in screws, I have a trainee putting in screws, I'm putting in screws, I don't really have to think about the trajectory of the screw. I'm thinking about tactile feedback, but I know these screws, and I'll show you the data, are going to be 99 to 100% accurate with good technique. Certainly, it allows for surgeons to put in screws who want to do MIS technique with less cognitive burden. Perhaps it allows for surgeons to more readily adapt MIS techniques. And speed, it depends. I think a lot of seasoned surgeons will tell you the robot slows them down. I can certainly make an argument that for longer constructs, the robot will speed you up. Proven benefits of robotic technology, the literature supports this. Certainly excellent accuracy, like I said, I'll show you some of the data. And certainly decreased radiation. Not decreased radiation compared to CT nav, but decreased radiation compared to traditional fluoro. And so once again, radiation exposure to yourself, your team, your sales team, your patients, certainly a benefit of robotic technology. In terms of accuracy, I covered up the robots. There were 7 robots listed here. It really doesn't matter what the brand name was. But the accuracy is 98 to 100%, but with the caveat of good technique. You have to have impeccable technique. You have to be you have to pay attention to detail. You have to make sure your accuracy is correct. But with good technique and good support, your screws will be 98 to 100% accurate. I'll tell you, I've put in over 1,000 screws. I've never once revised one. I've had 2 lateral breaches, which we noticed right away, and it wasn't actually that the screw or that the drill and the tap were off. The screw kind of skived lateral, super lateral, very safe. I've never once had to revise a patient with a robotic screw placed. I've never had a neurologic deficit with a robotic screw placed, and we really challenge the robot. We'll put in, screws in AIS patients with, type D pedicles. We're pushing the robot to the extreme, and we've never had a medial breach or a neurologic issue. Is it worth the cost? Certainly a hot item to discuss. The answer is I don't know, but I'll show you some of the data on both sides. One showing that the robot might be cost effective, and certainly some data showing that the robot is too expensive as it currently stands. So some of the costs, these are rough numbers. Every system, every design, every purchase is designed differently. They're all on different contracts. But most of the platforms that you guys have heard about, at least on their face value, are over $1 million, which is a huge capital expense for some health systems. I'll tell you, my institution, Keck Medical Center of USC, we purchased the robot outright. We just bought it at cost. We did not do an implant deal. We did not rent it. And the reason for that gets into accounting, but it has to do with depreciation. So not only is there a significant capital cost, but the disposable cost per case is not negligible. I know my data. My data is about $1,000 a case of just disposable stuff to use with the robot. I'll tell you, companies are working on getting that down, trying to use more reusable things, trying to minimize workflow steps, but the cost is not negligible. And so in my institution, $1,000, that's half of an interbody. That's about 2 screws. So definitely not negligible. And certainly we need to work on justifying this cost with benefits of robotics, whether it's decreased operative time, lower complications, less revision, improved patient outcomes, shorter length of stay, et cetera. Don't worry about the details of these studies. This is purely to prove a point. This is one study that basically showed with their sort of assumptions, their data, their 1-year analysis, that a robot potentially could save a health institution $700,000. How? Less revision, a conversion of patients from open to MIS, therefore shorter length of stay, better overall capturing of profit on a particular DRG code. Just a point, don't memorize the study. The point is, if you want to find a study to support your purchase of a robot to your healthcare system, there are studies out there that can potentially make it a cost-friendly purchase. Here's another study, complete opposite end of the spectrum, showing, long story short, that on a quality-adjusted life-year basis, the robot costs $600,000, which is ridiculous. Like, generally, when we're talking about quality, we want it around $50,000 per quality-adjusted life year. This was $600,000. So once again, two separate studies, completely opposite ends of the spectrum, but the cost is certainly something that all of us are worried about and are concerned about when we're thinking about acquiring this, what I think, beneficial technology. And so why is it tough to understand if a robot is cost effective? Well, one, there's significant variance in the amount of cost required to purchase a robot, because you can structure these deals in a multitude of different ways. You can get a robot for free if you're willing to increase your utilization of a particular company's implant. You can do it on an earnout where you basically get a rebate every quarter. You can lease it such that your purchase or your lease payments eventually go towards purchasing the robot. So it's really hard to understand on a national level how much each institution is actually paying for this capital cost. And like I said, variable cost is not insignificant. My personal variable cost is about $1,000 a case, but I've seen some systems where it's as high as $2,000 because you actually have to pay for the support of the robot expert to be in your case if you want it, so it can drive up the cost substantially. Is there an added value compared to just traditional navigation? Tough to say. Robotics might actually be slower, certainly in 1 or 2 level cases. Fluoro exposure compared to just regular navigation is probably about the same. And accuracy compared to regular navigation is probably about the same, but I think fair to say more accurate than fluoro and freehand, not that that has a necessarily clinical impact. And a lot of the savings from the utilization of robotic technology, it's difficult to capture, right? It's hard to really objectively capture how many patients are converting from open to MIS because of robotics. And I'll tell you, in Los Angeles, where it's a very competitive market, I get a lot of second opinions. And the way I sway a lot of those second opinions, if they want, it's not intentional, it's probably unintentional, is I tell them we do the surgery with the robot, and every person is just like, wow. And they think the robot's like doing the surgery, which is obviously not true, but I don't necessarily correct them. But it is a bit of a marketing play, and it works pretty well. And of course, we're able to put these screws in through very small incisions because the robot can see a lot more than we can see. Future of robotics, this is something that I'm very excited about, very passionate about. The robot needs to evolve, right? Right. If you talk to a critique of the robot, they'll call it a fancy drill guide, right? Which is very fair. Right now, most robotic systems just put in screws, but they need to do more. I'll tell you, some of the robots out there can hold retractors for your laterals, which we'll go over in a bit, for your T-lifts. Almost every company is working on getting the robot to do more than put in screws to help with bony decompressions, to help with osteotomies, to help with facet resections. Ultimately, with the integration of MRI or MRI-based CT, I think there's going to be an opportunity for soft tissue dissection. There are a couple robots that are coming out that are actually 2-arm systems. So I think in theory they're going to be able to do more like the Da Vinci, like do your decompressions, do your ligamentum flavum resections. So that's all coming, I promise you. I call those 3rd-generation robotics, and that's something I'm very excited about. We need to get better at optimizing workflow. Right now, when you try to set up a robot for your first time, it's going to slow you down 30 minutes at least, and that really frustrates, seasoned surgeons. Full automation systems are coming, and if you go on LinkedIn, you'll see some stuff. Integration of robotics with predictive analytics, very cool, very hot sort of topic. Biggest thing for me is we got to lower the cost, smaller footprint. Some of these robots take quite a bit of square footage in your OR. In terms of workflow, there's a lot of different ways to set up your robot to acquire images. Most systems can use a pre-op CT, and then you can merge that pre-op CT with an AP and oblique fluoro, and then your pre-op CT will be live. If you don't have a pre-op CT and you have a ability of a 3D imaging software, whether it's a Zeem or a G-arm or an O-arm, you can spin that in the OR and then merge the images with the robot and go live with navigation. There's pros and cons to using a pre-op CT versus an intra-op CT. I think if you have a lot of, like if you're doing an anterior or lateral-based procedure and then you're flipping, sometimes the metal from those cages can make the pre-op CT very difficult to merge. So oftentimes I'll use an intraoperative CT for those cases. If you're using the robot for fractures, be careful because those patients will move on the bed. And so the pre-op CT might not be as accurate as the intraoperative CT. So for fracture cases, I tend to spin in the OR. The downside of using the intraoperative O-arm is if you lose your registration because the patient bucks or trainee hits the reference frame, most systems need you to respin. If that happens with the pre-op CT, you can just take another oblique and AP and you're back live. And so that's a little bit of an annoyance. Another thing I'll say about the intraoperative CT is your image quality, especially in an obese patient, is not quite as good as the pre-op CT. So if you want the CT scan to be able to navigate your inner bodies or do your bony decompression, you might be better off with the pre-op CT. So like I said, the reasons I'll use a pre-op CT, longer construct, I can plan all my screws at home. Challenging anatomy, revision anatomy, where I really want good imaging, I'll use a pre-op CT. And in an obese patient, it might be better to get a pre-op CT. Once you've registered, whether it's pre-op CT or intra-op CT, you plan your screws. Every system's a little bit different, but it's very intuitive. The biggest reason I like using a pre-op CT is when I'm doing a long construct with the custom rod, I really like to drive up the cost of my surgery. The problem with the custom rod is if the rod doesn't mate with the screws, then you're adjusting the rod and you've lost some of your built-in preoperative goals. The nice thing about most robotic platforms is they'll tell you if your screw trajectories are going to marry with that rod without any issue. Like, for example, these screws that are in pink, it's telling me, hey, you need to adjust these screws a bit so you don't have to adjust your rod. And so I really like that. Let's see. In terms of putting in screws safely such that you don't have any issues, make your skin incision in line with the planned screw trajectory. Do your screws before you place your inner body. You want to use the inner and outer dilator. Once your inner dilator is down, you want to actually back it off because that inner dilator is very blunt and it will skive. And so you don't want that directly on bone. You want your drill to be the first thing that touches the bone. And just like Jens was saying, start that drill off of bone and use a high-speed drill. That's probably one of the other biggest advancements in robotics is the high-speed drill that now spins at 75,000 RPM as opposed to 2,500. Far less issues with skive. And so I generally drill, then I tap, and then I put the screw on. There are some systems where you don't need to tap, but I typically tap. After you place your screws, you can do your inner body work. For my standard MIS T-lift, we take an AP and oblique, and then we take 2 final C-arm shots at the end, and we don't use the C-arm at any other point during the case because we can do the rest of it just off of the live nav. So just one of the things we try to do to make the robot do more than just put in screws. Just one slide on tips and tricks. Soft hands. Don't fight the robotic arm. The robotic arm is in line with your planned screw trajectory as long as you're positive that you've registered accurately. You have to double check accuracy. The biggest reason, and Dave's group published this, for missed screws, 50% of missed screws are frame shift issues. And so you have to double check your accuracy. And so we are very, very diligent about that. We not only touch soft tissue landmarks, we touch the robot. And so we make sure that the robot knows where it is in space. And if there's any deviance, we register. Don't fight the robotic arm. Like I said, there's a bit of variance in the system, and I'll show you guys this in the lab. The spheres that the cameras are seeing are circles. And so even if you don't move the instrument, but you rotate the spheres, you will see motion on the navigation system. And so you might be a little bit off on the navigation, but I promise you that robotic arm is in line where it needs to be. And so don't try to fight the arm to make the navigation look like a perfect line. I think once we get to more flat spheres as opposed to circles, that variance will go away. The problem with that is you need more cameras. What else? Don't fight the soft tissue. Generous fascial releases. You don't want to fight the fascia, and that's going to cause you to skive medially. The worst case, in my opinion, to use the robot, 1-level open fusion obese patient, unless you're willing to make separate incisions, because you're going to fight a lot of soft tissue, and that's where you get medial skive. Intraoperative neuromonitoring, personally, I shut it off during screw placement in the lumbar spine. I turn it back on after we're done. I ask anesthesia to drop tidal volume to make sure the patient's not rising and falling with each breath, if possible. And so these are just some of the things we do to make sure that we stay accurate. And the biggest thing, like I said, people who don't like the robot, they don't like the workflow because it takes a while to set up. And I'm very fortunate to get the same team every time. And so I always tell them we try to run this like a NASCAR pit crew. And it's we can do this without talking, but it took about a year to develop that team. But I think that's the biggest reason, if people come watch, they say, okay, we can do this in about 20 minutes. It's because we get the same team every time. If you get a different scrub tech, different C-arm tech, it's miserable to use the robot. So you really try to get the same team. But ultimately, I'll leave it with that. Look forward to showing you guys this in the demo a little bit later. But MIS really drove robotics. Navigation with robotics was a game changer. We need to prove the benefits of robotics. Right now, it's very costly. We need to drop the cost, and third-generation robots are quite promising, in my opinion. Thank you.
Any questions for Dr. Alluri? Yeah, go ahead.
I have more. One of the questions I have is with the advent of, first of all, CT-guided screw placement, and then especially with robotics. What are your thoughts on the educational kind of loss of freehand screw placement or traditional floor placement?
Yeah, that's a very smart question, and you cannot be dependent on the robot or a CT scan to place screws. I'll tell you, there were a couple cases when we first started where the robot just crashed and we gave up. I didn't abort the case. So you have to understand basic fundamentals of open screw placement, fluoro-based screw placement. It's a bad day if you're dependent on the robot, and we failed you as trainers and mentees if that's the case. So do not lose track of your fundamentals.
I would just mention that, on my service, I use robotics as well. I think it's a great technology. But Rod, Dr. Iskarian, uses it far more than I do. So fellows come off his service onto my service. I almost always do a freehand fluoro-based case just to see that the fellows are still holding those techniques. And it's a little bit of a, learning curve there. And unfortunately, we're here, we do a full variety. Jens very rarely will use a robot, so you get a good spectrum. But, that's a challenge with us in education is knowing how much is enough in terms of traditional and how much is enough in terms of exposure to new techniques, because I think they're all very valuable. One question that I have for myself, and I've struggled to convey to patients is, what is the patient exposure to radiation? So, we need a fine cut CT. I've heard conflicting information from the actual, radiologists that do these, whether the source information is the same, it's just how it's processed. Is it actual more radiation that we're getting with a traditional 2 millimeter cut versus a fine cut? Is there anything that you've seen in terms of, are we exposing patients to more radiation by doing these robotic techniques?
Yeah, I mean, certainly we are, right? Because most systems require 1 millimeter cuts versus the traditional CT is 2 to even sometimes 4. But some of the things we do to minimize that radiation is if I'm doing like a 4 or 5 MIST lift, I'll tell the radiologist to just scan like 3 to 5. And so I really try to minimize the amount of exposure necessary for the pre-op CT. And then intraoperatively, we always try to optimize our dose settings, low dose, if it's not an obese patient. But certainly we are exposing the patients to, higher radiation with the robot or even just traditional nav. But I don't have a quantitative answer for you.
Thank you. Any other questions?
The question about how do you learn open is real. We have 35 spine surgeons at Cedars. We only have 2 of us who do it by hand open anymore. It's becoming a lost art, and I think things like this cadaver course is one of the places you could put in the most open screws and feel what it's like to be in the wrong place, feel what it's like to go through the medial, cortex into the cord. So I take advantage of this.
Yeah, and to Dave's point, when I'm using the robot, I'm actually not looking at the screen. I'm feeling in my head. And the only way you know if it feels correct is by doing it freehand first. Thank you.
Great. Yeah, thank you.